right, good morning. Thank you for inviting me. My name is Dr. Brandon Vanderwel. Yeah, so thank you for inviting me. It's my hometown of Colorado, which is really exciting to be back. It's also a great day because 2 years ago today was my very first ESG. So since that time, we've actually done over 200 in our program. I'm currently a consultant for Apollo Endosurgery, which no one is more surprised than my wife that someone pays to listen to me. So, why do we need endobariatrics? I thought this would be a good way to kick off this panel discussion. Population of the United States, I know many of you are from across the world, but population of the United States is 330 million. 27% of that has a normal BMI. 31% is obese. 33%, 108 million people are obese in the United States. And 9%, which is 30 million people, have severe obesity. That's a combination of 138 million people. If you put those people into their own country, they would be in the 9th largest country in the world. So, this is quite literally and figuratively a massive problem. What do we do to treat obesity? We have the tried and true, diet and exercise, eat less and exercise more. Medical weight loss, we have the newer endobariatric procedures, which we're talking about today. Intragastric balloons been on the play for a while. And then there's the laparoscopic bariatric surgeries. Bariatric surgery has been the gold standard for decades, scientifically proven, certainly the best treatment that we have for obesity. So how much of this very large section of a pie graph gets the gold standard treatment? That much. Do it again, in case you missed it. That much. A fraction of a fraction. Less than 300,000 patients every year get bariatric surgery. So, why? Why are we underutilizing the gold standard? I conceptualize this. I can think of this as in the terms of a Venn diagram. You kind of have to get through 3 major hurdles. First is denial. Do you have a problem? Or I can fix the problem. I can or I can't. Once you kind of see, okay, I have a problem, you try some things, you can't fix it, and you're like, I'm stuck. Okay. Next step, what's the next best treatments? Most people, a lot of patients know now that bariatric surgery is the best treatment. But there's a major fear, hesitancy component for patients getting past that barrier of just mentally accepting bariatric surgery. Once they get past that barrier, then it just comes down to cost usually. But I just can't emphasize enough that fear component probably stops tens of millions of people from taking that next step and seriously considering bariatric surgery. So that is why we need more tools to treat obesity. It's because there is a huge problem that it needs addressing, and there is a major obstacle that a lot of patients have to getting addressing. Endobariatrics, I think, really bridges that gap. I believe in, I kind of start with my take-home points, since I think if you're looking for cliffhangers at a scientific session, then I'm sorry for you. We need more tools to treat obesity. The endoscopic sleeve gastroplasty is a procedure that endoscopically sutures the stomach from the inside and shapes it into the sleeve configuration without removing any tissue. Weight loss results are in the 15 to 19% total body weight loss, excess weight loss 49 to 79%. 5-year data showing 16%, improvement in medical comorbidities and a very good safety profile. Long-term data is limited, but encouraging. And the ESG is a safe and effective tool to help patients with obesity that feel that surgery is too extreme for them. So, without further ado, the endoscopic sleeve gastroplasty, also known as the ESG, also known as the endosleeve, also known as the accordion procedure, is an endobariatric procedure where you have an endoscopic suturing device. The only one available in the United States that's FDA approved is the Apollo Overstitch. There are other devices that are available internationally. You use that suturing device to suture the stomach with full thickness bites. Grab a portion of the stomach, take a full thickness bite through there, and in multiple series of bites, then you use that to cinch, usually about 4 to 11 sutures to cinch down the stomach into a sleeve configuration. The Apollo Overstitch, should be noted, is FDA approved for tissue approximation. Doesn't have a technical endoscopic sleeve gastroplasty indication, though I'm told that it is in the process. There is international experience with other endoscopic suturing devices. The first ESG was performed in 2013 at Mayo Clinic. Since then, over 20,000 procedures have been performed worldwide. 200 publications, over clinical results of over 2,000 patients, and just recently, the beginning parts of the study of the MERIT study, which is a randomized controlled trial that shows ESG versus behavioral therapy, showing that ESG is superior. So I have a little scoreboard here for you to help keep track at home. ESG results. So this is Hedija et al. Published a large meta-analysis of almost 1,800 pooled patients at 18 and 24 months. Total body weight loss, you can see here at the bottom. I know this is, you see at the very bottom of this chart, total body weight loss is 17%, excess weight loss is 67%. Serious adverse events in this group were 2%. Those included pain requiring hospitalization, perigastric fluid collection, and a GI bleed. There were no deaths or critical illnesses reported. So the MERIT study, like I previously alluded to, is just presented at IFSO a couple of months ago. It is a 200-patient randomized controlled trial. It's a crossover design comparing ESG and behavioral therapy. Excess weight loss was 49% at 12 months and was maintained at 24 months. Behavioral therapy experienced a 4% excess body weight loss, which, after crossover to ESG, also improved to 49%. Total body weight loss was also 16%. Serious adverse events were 2%, with a perigastric fluid collection and an upper GI bleed. And malnutrition was suggested to require an endoscopic reversal. Medical comorbidities that were examined were type 2 diabetes that showed an improvement of 35%, and a complete or partial remission in another 35% of diabetics. Hypertension improved in 45% of patients and had a 17% partial remission. Quality of life scores also significantly improved for patients after ESG. GERD was also noted to significantly improve in these patients. So here's our longest data set that we have in the ESG, which is unfortunately just one 5-year paper from Shariah et al. In NYU, who have published this 5-year data set that shows that patients are able to maintain their total body weight loss of 16% at 5 years, and they had a 1% serious adverse event rate. So, how does the ESG compare to other modalities that we use to treat obesity? Compared to the endogastric balloon, the Singh et al. Published a meta-analysis comparing ESG and intragastric balloon, showing that the weight loss was superior with the ESG at 18 to 24 months. 17% total body weight loss, you can see there in the top left portion of that graph. Excess weight loss was 67%, 66%. Intragastric balloon saw 7% total body weight loss and a 23% excess body weight loss. So this is what people are very interested in, is how does the endoscopic sleeve compare to the laparoscopic sleeve? A 2021 meta-analysis by Marincola et al. Pooled 16 studies and compared the LSG to ESG. These were not cross-matched. Pooled LSG results were 80% excess body weight loss, as seen in Group A, the top, and 62% excess weight loss, as seen with the ESG group in Group B. Serious adverse events were 3% for the laparoscopic sleeve group and 1% for the ESG group. This is a theme we'll consistently see, that weight loss for the ESG is strong, but not as good as the laparoscopic sleeve gastrectomy, but the ESG does have less complications. Along this vein, Wang et al. Published a paper in 2020 that reviewed matched and unmatched ESG versus other weight loss modalities. These studies were consistent with previous findings. For the ESG, total body weight loss is seen in the 15 to 19% range, as seen in multiple of these comparison studies. Serious adverse events were 1 to 4%. Statistical analysis demonstrated that laparoscopic sleeve gastrectomy statistically significantly was better in weight loss than the ESG, but the ESG was statistically significantly better than the intragastric balloon. The ESG had a lower complication rate than the LSG and the intragastric balloon, and these findings were also statistically significant. So, in summary, endoscopic sleeve gastroplasty, or the ESG, total body weight loss around 15 to 19%, 49 to 79% excess weight loss, serious adverse event rate of 1 to 4%, and improvements in medical comorbidities. Strong weight loss, strong improvement, it's safe. Is it perfect? Is it the best thing since low-carb sliced bread? Well, of course, there's no perfect bariatric surgery, we all know that. It doesn't have as much weight loss as the laparoscopic bariatric surgeries. It does have the issue of if those sutures are not placed correctly, there's about a 10 to 7% failure rate in the early stages of the procedure, which improves generally, get to the lower reduction rate with time and experience. It has limited long-term data that it's just going to take time for us to accumulate. It's a technically challenging procedure to perform that has a long and steep learning curve, and you need the support of a comprehensive bariatric team, which I probably don't need to tell many of you in this room. With the RD, and ideally, a full multidisciplinary team with a PA or nurse practitioner as well, and bariatricians. So, reviewing the take-home points again, we need more tools to treat obesity. The endoscopic sleeve gastroplasty endoscopically sutures the stomach from the inside, does not remove tissue. That's a big sticking point for a lot of patients, and shapes the stomach into the sleeve configuration. Total body weight loss is 15 to 19%. Excess weight loss is 49 to 79%. Serious adverse events are 1 to 4%. Long-term data is encouraging, but we need more. And the ESG is a safe and effective tool to help patients with obesity that feel that surgery is too extreme for them. So, thank you.